you to the Magnus Group and the organizers today. It's been a great day. Thank you for having me again. So today I'll be talking about ipsilateral heterotopic ossification in the knee and shoulder joint post-COVID-19. This is a case report and a brief literature review. It was conducted at the Royal Wolverhampton Hospital and input from colleagues at Stoke. I have no disclosure and my colleagues have no conflicts of interest. The patient was consented for all anonymous data to be shared and presented for educational research purposes. So, heterotopic ossification, a long word, what does it mean? It's abnormal formation of extraskeletal lamellar bone in normal soft tissues and can be acquired or hereditary. Myositis ossificans is a term used to describe formation of ectopic bone within large inflammatory muscles and soft tissues. They can be used interchangeably, but HO is a more descriptive term. It was first described in paraplegic patients in World War I by Riedel in 1883 and De Jern and Sellier in 1918. Novel heterotopic ossification has reported over 32 cases within the literature secondary to severe COVID-19. It involves, usually in the literature, bilateral large joints, and it's a delayed onset. And there's very little published evidence of ipsilateral novel heterotopic ossification. Acquired HO is seen in hips and the lower limbs, secondary to trauma, surgery, burns, strokes, amputations, or neurogenic causes. And we see it a lot post-total knee replacements, post-total hip replacements. There's hereditary causes as well. And essentially, there's new bone forming in non-osseous soft tissues. Myers et al. Described that 75% of HO cases initially have a history of trauma. Frequency varies from 15 to 90%, with 30% in the population of primary hip replacement. According to the Toronto ARDS study, there was a 5% prevalence of patients admitted to intensive care with acquired HO. So on average, it can take 12 months to develop and mature. Hip HO can be classified according to Brooks or Schmidt, and Hackenbrook for more extensive classification. It can be diagnosed using plain film x-rays, be treated operatively or non-operatively. Surgical management may be undertaken if the ectopic bone formation results in nerve damage, such as motor sensory disturbance or uncontrollable pain or stiffness, but they do well with conservative management. If you do end up operating on these, the lesion may reoccur and the range of motion improvement may only be temporary. Pain relief is unsatisfactory with surgical excision, and non-operative interventions include physiotherapy, analgesia, and some new studies have done pulse ultrasound, electrophorophoresis, or extracorporeal shockwave therapy. This is what it looks like under a microscope. This is what it looks like in this 3D recon CT scan. So our case was a 58-year-old gentleman who presented with type 2 diabetes and COPD, with the background of type 2 diabetes COPD to the A&E. He had a 5-day history of worsening shortness of breath and an unproductive cough. He was admitted in the red area of COVID when COVID was a huge thing. And he came under the medical team as COVID pneumonitis. He deteriorated respiratory-wise and ended up in the ITU and was intubated for a total of 33 days. Whilst he was being extubated, his knee on the ipsilateral side looked swollen compared to the other side. So the physiotherapists were involved, they did some movements and they were concerned, so we got some x-rays. He had a limited range of motion, his power was reduced, and the shoulder on the same side was showing similar signs. The ITU team correctly got some x-rays of the shoulder and the knee, and they sent a referral to us to have a look. His contralateral joints remained unaffected. So I know there's a lot of information on there. I'm not going to read all of it. Essentially, he had obvious signs of infection. CRP was high. His procalcitonin was high. He was treated multiple antibiotics. He was obviously in ITU immobile for 33 days. And comparing his x-rays from pre-ITU, so his chest x-ray, and comparing his x-rays of his knees pre-ITU to post-ITU showed he had amorphous calcification and immature ossification within the muscle, an appearance in keeping with HO of the knee and shoulder. Now, we think it's HO at this stage, but we have other differentials as well. He could have ITU-acquired myopathy, he could have had a stroke, he could have had septic arthritis, hemarthrosis, could be osteoporotic fracture. The final diagnosis was eventually achievable with an plain film and MRI. Pre-ITU, he had never complained of any shoulder or knee pain. He's very active, mobile, independent gentleman. So looking at his x-rays, this was his pre-admission x-ray, pre-ITU admission x-ray, which is kind of a standard they do just when the patient is being immobilized for a prolonged period. And post 2 to 3 weeks after his intubation, you can see the development of HO there on the lateral aspect and the medial aspect there. And on the lateral view, you can see there's formation of bone in the soft tissues. Looking at his chest x-ray on admission, not really much there in the shoulder. I don't know if you can appreciate that with the arrow pointing to slight development 2 weeks later of HO in the right shoulder. Coming down on in this picture D, looking at a lateral view, he also has, as you can see, amorphous bone calcification in the soft tissue around the right shoulder. Looking at his MRI images in T2 and T1, so you can appreciate that there is some new formation of bone in the musculature there, soft tissues. And looking at axial cut, it's quite significant around the knee. So we decided to treat this conservatively. He had good physiotherapy, good pain relief. He's regularly reviewed by the pain team to alter his analgesia accordingly. We decided that surgical interventions in this instant would not be of benefit. If we were to go down the surgical route, it would involve removing part of the quadriceps muscle, leading to further prolonged immobility and a potential recurrence of disease. And there were the added risks of general anesthesia, and the patient already has COPD through COVID pneumonitis. He's been intubated, and a potential of a poor quality of life for a patient who is completely normally independent and active with no aids or assistance pre-morbidity. So what did his rehabilitation involve? Post-ITU, he was initially being hoisted into a supportive chair due to the weakness of his muscles. Ongoing physiotherapy and optimization of analgesia with opioids and non-steroidal anti-inflammatories. And he initially required a transfer of assistance of 1 from his bed to a chair, and he could use a commode at the bedside easily. There still remained a prolonged limited range of motion of his ipsilateral right knee and shoulder, and he has suffered from some post-ITU insomnia. Further physiotherapy, daily reviews, good pain relief, and eventually we were able to send him back to a rehabilitation facility close to his home. Here, he stayed there for 3 months, and he recovered really well, and he was back to his normal life. He works as a mechanic, and he was back to his normal daily activities. There was no need for an orthopedic follow-up, and we safety netted him, and he continued seeing the physiotherapist, occupational therapist as an outpatient. So what does the literature show? Thorough search of Medline 2020 to 2023 showed there's 32 reported cases of widespread bilateral HO formation after prolonged immobility secondary to severe COVID-19. Mara et al. Describes 4 cases in which HO was in the hips and the shoulders. Aziz et al. 2 cases with similar HO formation. And the story goes on. There's 10 out of 52 patients after COVID-19. Another Brands et al. Reported a case of a normally fit gentleman with progressive HO in the shoulder, elbows, hips, knees, and ankles. And there's a common trend. They all seem to be bilateral. So how does this happen? We think it's probably because of COVID-19. That can cause an alteration to tissue repair involving the use of osteoprogenator cells, signaling pathways, and a suitable environment promoting osteogenesis. There's limited knowledge currently in the literature on precise molecular pathways leading to HO. A short-term development of ipsilateral HO post-COVID-19 may be secondary to immobilization. As we have discussed, comparison with pre-morbid and post-morbid images have evidence of new formation. COVID-19 is a severe inflammatory immune response and can lead to extensive secondary pathological processes. And a hypothesis may be ectopic bone formation within soft tissues. It's just the body's way of reacting to potential severe illness. The disadvantages of developing novel heterotopic ossification are lengthy hospital stays with a high risk of chest and urine infections. Advanced rehabilitation physiotherapy planning is important in these patients' care. so you can get them back to as close to their pre-morbid mobility. Further clinical trials are needed to prove an evidence link between COVID-19 and acquired novel HO. So far, the literature is only case reports. We need to aid improvements in early clinical diagnosis, treatment, preventative measures, and rehabilitation planning. These will help assist in establishing whether baseline plain film imaging is recommended in patients staying or expected to be in ITU for a prolonged period. Diagnosing novel HO earlier can support physiotherapy and rehabilitation. In conclusion, HO and MO are interchangeable terms. Heterotopic ossification is more commonly used due to the descriptive terminology of the condition. Acquired HO most frequently occurs post-joint replacement surgery. Prolonged immobility due to trauma, surgery, CNS disorders, and paralysis can lead to formation of acquired HO. Prolonged COVID-19 may trigger severe inflammatory cytokine immune response, which can lead to formation of HO intra or periatrically. Literature displays large joints may be affected by novel HO post-severe COVID-19 and describes cases with bilateral HO formation. This case is unique because it describes ipsilateral novel HO of the knee and shoulder after prolonged severe COVID-19 intensive care stay. The formation of new bone and muscles or around joints in HO can be treated conservatively with similar outcomes as surgical interventions, and development of HO may lead to prolonged hospital stays and increased risk of infections. Rehab and physiotherapy is important. Further studies are needed, and we'll be able to define post-illness management protocols to guide early recognition and treatment for these patients. These are the references, and thank you. Any questions?